Welcome, everyone. I am so incredibly thrilled to have you here for this Master Explainer, because today we are fundamentally shifting the way you think about patient care. We're diving straight into the foundations of pediatric nursing. Look, if you've been studying adult med-surg, you need to hit the reset button right now. Why? Because a kid is not just a miniature adult. To really master pediatric nursing, we have to look at the patient through a completely different lens, one of constant growth, rapid development, and complex family dynamics. I know looking at 19 dense syllabus objectives can feel a bit overwhelming, but don't sweat it. We've neatly organized everything into 4 straightforward sections: foundations of pediatric nursing, performing pediatric assessments, development across the lifespan, and finally, care of the hospitalized child.
All right, let's jump right into Section 1, Foundations of Pediatric Nursing.
Okay, so in adult nursing, you're usually dealing with a pretty static developmental state and an independent client. But in pediatrics, it is a whole different ballgame. Your patient is continually growing and developing. Their normal vital signs, their anatomy, their physiology, even their safety risks literally change by the month and sometimes even by the week. Plus, you aren't just treating the child, you are treating the entire family unit. Just treating the disease is never enough in pediatrics. And that brings us perfectly to our 2 core priorities. These basically govern everything a pediatric nurse does. First up, family-centered care. This means forming a true partnership with the family. You absolutely must recognize them as the experts on their child's baseline behaviors. Second is atraumatic care. This is the art of reducing physical and psychological distress. It means minimizing separation from the parents, giving the kid choices when you can, and using the least invasive options possible. Our goal is to heal them, not traumatize them.
Now, a great pediatric nurse is also a fierce advocate. We have to keep a close eye on current trends and the social determinants of health. We focus a ton on prevention, like primary prevention with immunizations, and tackling major issues like the multifactorial causes of obesity. Oh, and here is a huge test tip for you. Never, ever judge a family structure. Instead, just assess how it impacts the child's health. Are limited resources affecting what they can eat? And always be on high alert for safety red flags, like delayed care or a kid who can't speak for themselves. Those could actually be signs of human trafficking.
Moving right along to Section 2, Performing Pediatric Assessments.
We need a very specific toolkit to actually examine and talk to this unique population. Communication in peds is this 3-way street between you, the child, and the caregiver. But let me ask you, who's the client? Well, the child is always the primary client. Sure, you're absolutely going to rely on the parents for the health history, especially with babies and toddlers, but you must never just talk over the child because a parent is in the room. Get right down to their eye level and adjust how you speak to match their developmental stage. When we're looking at nutrition, a pediatric assessment has 5 standard components, ranging from clinical history all the way down to diagnostic tests. But honestly, here is the absolute golden rule for pediatric nutrition. Isolated measurements mean very little. What actually matters are the trends. Following a child's overall trajectory on a standardized growth chart tells you way more about their health than one single weigh-in ever could. And as for the physical exam, well, the most important step actually happens before you even lay a finger on the kid. You start by just standing back and doing a general survey. Watch their behavior, how they're breathing, how they play, and how they interact with mom or dad. When you do step in, adapt it to their age. Use play. Let a toddler hold your stethoscope for a minute. And definitely always leave the scary, invasive stuff, like looking in their ears or their mouth, for the very end.
Notice how pain assessment tools absolutely must map perfectly to cognitive development. You cannot ask a 2-year-old to rate their pain on a scale of 0 to 10. It just doesn't work. So instead, we use behavioral scales like FLAC for the toddlers. Then we move up to the FACES scale around age 4 when they can visually understand expressions. And finally, we graduate to the numeric scale around age 7 when abstract numbers make sense to them. The tool has to match the brain.
Let's slide right into Section 3, Development across the lifespan.
Look, you simply cannot spot a pediatric emergency if you don't know what normal looks like. This is an incredibly rapid biological journey. An infant is growing so fast they will literally triple their birth weight by their first birthday. That's wild. Then, physical growth kind of slows down during the toddler and preschool years, while their cognitive and motor skills absolutely explode. And it picks up steadily until the adolescent hits those major pubertal and hormonal changes. Your assessment findings are entirely dictated by where your patient sits on this timeline.
Every single stage is driven by distinct behavioral themes.
Infants, they're all about trust and attachment. Toddlers are completely driven by autonomy. Their life motto is, "I do it," which, totally explains the tantrums. Preschoolers live in this literal world of magic and imagination. School-age kids are seeking competence and want to cooperate with their peers. And adolescents are entirely focused on figuring out their identity and getting some privacy.
Because you know these milestones, you can easily tell the difference between expected and unexpected findings. This is absolutely crucial. A temporary regression, like a fully potty-trained toddler who suddenly starts wetting the bed in the hospital, is a totally expected stress response. But a true loss of a milestone they already mastered, or just failing to meet one altogether, that is an unexpected finding, and it means we need early intervention therapies right away.
Development also directly dictates safety. Unintentional injury is a massive pediatric risk, so anticipatory guidance is your best friend. For infants, we worry about safe sleep and choking hazards. For toddlers, their mobility increases way faster than their judgment. They will happily climb right into poisons or a pool without a second thought. Preschoolers need traffic safety, school-age kids need sports helmets, and adolescents need real talk about safe driving and substance use. Always connect the safety risk right back to their developmental stage.
Okay, final section. Section 4, care of the hospitalized child. Now we are going to take this developing child and drop them into one of the most stressful environments imaginable, the hospital. Hospitalization threatens the core developmental task of every single age group. For infants, it disrupts trust and causes major separation anxiety. For toddlers, it strips away their beloved autonomy and routines, which leads to epic meltdowns. Preschoolers, with that magical thinking we talked about, might literally view a medical procedure as a punishment for being bad. And adolescents just feel this crushing loss of privacy and separation from their friends.
So how do we combat this? Through play. And I want to be super clear here. Play is not just some distraction to keep a kid quiet. Play is an essential nursing intervention. It is the literal language of childhood. Giving them safe, developmentally appropriate play helps them process complex emotions, reduces their fear, and gives them back a tiny bit of control in a really chaotic environment.
When a child gets admitted, providing comprehensive care means you are treating the whole kid, not just the disease they came in with. Yes, of course, you address their immediate physiological needs first, but comprehensive care also means fiercely protecting their sleep, keeping up their normal developmental routines as much as you can, starting discharge planning on day one, and aggressively supporting the family unit, because let's face it, they are probably terrified and exhausted.
This all comes together through clinical judgment. The 6 steps are pretty standard. Recognize cues, analyze them, prioritize, generate solutions, take action, and evaluate. But in pediatrics, analyzing cues means you constantly have to separate expected developmental behavior from unexpected clinical deterioration. A toddler screaming because mom left the room? Totally expected. A toddler who is suddenly quiet and lethargic because their oxygen is dropping? Massive medical emergency. Actually, let's pause right here, because I really want to aggressively reinforce this concept for your exams and your actual practice. Whenever you look at a pediatric scenario, you must ask yourself, what is the risk? What could harm this child first? And what should I do immediately? Physiological instability and immediate safety threats will always outrank developmental inconveniences, every single time. So, to wrap this all up, here is your ultimate mental checklist for week 1. This is the exact framework you need to pass your exams and safely care for a kid. Ask yourself, what's normal for this age? What's the primary risk here? How do I involve the family? How do I need to adjust my communication? How can I give the child back some control through choices or play? Are there safety concerns? And finally, apply your clinical judgment. I'll leave you with this one final, provocative thought to really solidify your priorities. If you've got a 2-year-old throwing a massive temper tantrum because they want their autonomy, but simultaneously their oxygen saturation is rapidly dropping, do you treat the autonomy or do you treat the airway first? You protect the airway, always. Master this tricky balance of development and clinical risk, and you are totally ready to tackle the specific pediatric diseases coming up in the next modules. Thanks so much for joining me on this explainer, and let's keep that focused momentum going.